by Dr. John SARKAR, an excellent cornea surgeon, and also have a very keen interest in viral keratitis. And I have given him a very difficult topic. What are what are the recent advances in viral endothelitis? Dr. John, stage is yours.
Thank you, Dr. Prafullu, for giving me the opportunity, and thanks AIOS2025 for giving me this platform. So, very good afternoon to all of you. So, I'll be presenting the viral endothelitis, the future. I have, I have no financial interest. So, I'm just sharing some before my own talk, sharing few cases. 65-year male came with us for pain, photophobia with blurring of the vision right eye for 2 months with history recurrence of that time previously, with other is absolutely normal, and he sent to us for and diagnosed elsewhere as a phakic bullous keratopathy, and he was referred for endothelial keratoplasty. He was came like this feature, the area of stromal edema with the intact epithelium. There is no, and KPs are there, and the FS fluorescence staining negative. And age-old procedure we have done before staining, the corneal sensation reduced. And we do the ASOCT, and you can see there's plaque-like things there and the coarse endothelium. So probably I'm dealing with the case of the HSB. What we have done, give the topical steroid prednisolone given in 1% in tapering dose, along with the therapeutic dose of acyclovir, 400 mg 5 times 2 weeks, followed by the therapeutic dose 400 mg BD for maintenance dose. So, and the result is that after a couple of weeks, that comes with that is. So, no need for the endothelial keratoplasty for this patient. So, it sometimes mimic that you are dealing with. Sometimes you may refer to these things that you are probably dealing with the ABK or PBK. You have to take the history properly and clinical examination properly. Case 2 is that 47-year male with the history of female with the history of diabetes, pain and redness for 2 months, and same I had some distant episode of redness long back, and she had for last 2 months the cocktail therapy with the moxifloxacin, natamycin, acyclovir eye ointment, and referred to us for the therapeutic PK. She came with these clinical features. Eyes very much congested, the hypopenia was there, the stromal necrosis was there, and we have done the scraping almost last 2 months. She was getting the moxifloxacin, natamycin, and acyclovir, all comes negative. So what we have done with routinely with the scraping, and plenty of pustules are there, no bacteria, no fungus, and probably I'm dealing with the HSB1. We have started the therapeutic dose of the acyclovir. Along with that, as the eye was very much inflamed, and when the KVH was negative, oral acyclovir reduced the subset inflammation. Once the epithelium healed up, I started the topical prednisolone and tapered the rapid tapering of the oral steroids. And the result these things we have done the your acid tap for the HSB, and it comes positive. So these are some of the scenario. What we'll do for so the HSB keratitis remain the diagnostic and therapeutic challenges to the ophthalmologist, and it comes the diagnostic dilemma, recurrence, and the treatment strategies. And it has been very clearly that Manisha ma'am has explained these things. So they have the recurrence, why this recurrence and why this is explained very clearly explained to ma'am. So it's a HSB keratitis remain the leading infectious cause of the blindness worldwide, and approximately 1 to 1.5 million people and 9 recurrence is there, and causing 40,000 new cases every year. So highlight of the presentation, what's new in etiological aspects, what new in the diagnostic aspects, and what new in the treatment aspects. So this study and was published in this elsewhere, and is a eye opener of this why exactly what happened, and these things explain this thing. All of us know this that it has been almost century back with those explain this thing. There's existence of the endothelitis which has been well treated by the topical steroid. Subsequently accumulating the evidence has been shown that the disease etiology consists of various viral infection including the HSV, varicella zoster virus, mumps virus, and the cytomegalovirus. Sometimes we have found the Coxsackie and adenovirus too also, and Epstein virus. The pathogenesis of the corneal endothelitis is not fully understood when the role of toll-like receptor TLR and the pattern recognition receptor that initiate the innate immune response, and that is the most we have to hit that area, and the molecular level where I tried madam was trying to be inference these things. Now we grossly were even acyclovir topical steroid, but we have to be advanced in thinking for the at the molecular level. So this flow, I love this flowchart because the toll-like receptor pattern recognition receptors that initiate the immune response to the endothelial level, and why there is a recurrence is there, why the stopping these sometimes the cells embedded with the your virus load. So that why the where it is embedded the toll-like receptor 9 which recognize the bacterial or viral DNA and RNA containing the unmethylated sin, and that is immune reaction is there. I'm not going in details for the passage of time. The upregulation of the pro-inflammatory cytokines and the chemokines in the corneal endothelial level interact with the HSV1 and could be reduced by treatment of the which is toll-like receptor 9 inhibitory oligonucleotides. So their results suggest that the toll-like receptor 9 signaling the may play a major role in inflamed viral corneal endothelitis. So that's why with steroid is subsiding, but we have to be give the oral acyclovir or therapeutic doses. Along with that, we have to be things for the molecular level in advance of management. But so now clinical categories already that Sumit has very nicely explained. I'm going not in details. Mainly the disciform, diffuse and linear one. This is the clinical diagnosis. These are maybe the some things I'm skipping this size because already he has explained this thing very nicely on the first talk. So these are some of the patients who came with the your HSB recurrence in the graft one. That is really confusing whether it is HSB recurrence or is a graft rejection. So differentiating point is that, so the madam was initially asking, so if it is a HSB endothelitis, you will give the fold in the dreams and the records, KPs are there, and had a definite history of the recurrence is there. And shoot up IOP is one of the most prominent factor. So how to diagnose the HSB endothelitis? So diagnosis test is maybe the laboratory test, the viral culture, polymerase chain reaction, immunofluorescence assay, and the GM staining. Or imaging technique, it may be the antrosegment AIOS2025 in vivo confocal microscopy, or what the newer diagnostic done in the multiplex dose hybridization MDH assay or immunohistochemical assay or ICGA. So PCR is definitely the HSV DNA. The rapid one, the sensitivity is approximately 70%, and the type of it may be conventional PCR, the real-time PCR, or the multiplex PCR. What exactly PCR is doing? They much more specialize the things clinically assist your diagnostics. Whenever you are confusing whether I should give therapeutic one or not, specifically the first cases where I discussed there is a send you as a PBK or ABK. Then if you have a doubt of these things, it will give the very clear cut thing. If you do simple PCR in OPD process to also send for the your even also pen your PCR all the multivirus, I mean CMV virus, HSV1, HSV2, and if it's a single genome is there, it will multiply the thing and give you the result. So it will give you assist to the diagnosis and the treatment part too also. And I'm going and and it's very specific. The specificity is that 71.4%, and it also gives the quantitative assay for the real-time PCR, how much the virus load is there. So you can indirectly top up your dose of the oral acyclovir and accordingly, or the therapeutic one, how long you will produce. Another assisting diagnostic is that's your confocal in vivo confocal microscopy. What exactly you will get in the confocal microscopy? You will see the gutata enlargement on intercellular gap, and there is infiltration of the inflammatory cells in between the endothelial cells, and the loss of cell and defined the cell boundaries and endothelial denaturation. But the thing is that these are the showing this thing, this virally laden cell, and when you give the treatment with topical steroid along with the oral acyclovir, it comes normal. No signs of endothelitis 3 weeks after initial approach, appropriate antiviral therapy, and it has comes to become looks like a normal. But the limitation is that the viral particles which is there, they can't be limited. The limitation is there whether it is active or not or something. They can't be to confocal microscopy. Can't the pick up the things. So these are the another diagnostic modalities that the Shumit has explained the thing. Due to paucity of time, I'm just escaping. That can be things to rule out. And keratic precipitate, we'll see. This is the pre-treatment and the post-treatment, how it looks like the endothelium. And so whenever you are dealing with these things and you try to diagnose by the ASOCT, but always keep in mind on a loop that you should be rule out the phakic or pseudophakic corneal edema, Fuchs endothelial dystrophy, primary ankylosing glaucomas, or other HSV endothelitis like CMV, HZV, and the Fuchs heterochromatic iridocyclitis and Boxner-Stockner syndrome and eye syndrome. But now the treatment part. What's new in the treatment? As all of us know, this thing already previous speaker explained. The thing, the prednisolone acetate or the dexamethasone 0.1% has to be given. You have to pick a topical steroid along with that oral as a main mode of treatment. Whatever you are giving, the therapeutic dose is standard therapeutic dose 400 milligram 5 times 2 weeks, followed by 400 milligram BD for minimum 3 months or more than that, even sometimes 6 months or a year, depending on the clinical scenario and how the patient responds. And tapering of the steroid, what the madam was initially asking, and the Dr. Madam Manisha Ma was try to be clarify these things. Even sometimes, what usually my patient, I usually taper very slowly after when it is not like the cataract prednisolone, the 64321, even one alternate day, two alternate day, sometime and gradually like that, and with monitoring of the IOP, and most of the time HSB associated trabeculitis, we have to address the intraocular patient. So even with this, now what's new with that? Now surgical aspect, I'm not going in details. This patient came to us for this PBK. We have done the ultrathin dissect for this patient. Is a one-eyed patient, and I'm just skipping the video that because Dr. Praful was in the very nice video. The outcome of this patient is ultrathin dissect is that the one-eyed patient. You can see the visual acuity 6/12 and is unaided, and the other eye no pale. And this is the your specular microscope operatively and the AIOS2025. So what is the immunomodulator? Now the role of the tissue immunomodulator, specific treatment for the addressing the CD4 your receptor cells and the molecular level in human recurrence herpes infection. Both the CD4 and the TRM persisting between the lesion may control the asymptomatic shedding of through the interferon gamma section. Although this has been more clearly shown, the CD4 cells are more responsible for that.
John, can you please conclude in
Yes,
1 minute?
ma'am. I am just concluding. The role of the inflamed role of CXL is there, and role of vaccination. Yeah, combination of the herpes simplex vaccination strategies from the besides the two bench and back. That's mean whenever we have the things we are thinking of the vaccination, this means priming and pool vaccination approach. That's mean first priming the antiviral effector memory T cell and systematically then pulling them to the virus replication site, the sensory ganglion, and the replication site, the eyes or the vaginal mucosa, and that can have probably hit the suppression of the patient and the reduce the virus load, even also asymptomatic the HSB positive patient too also. And the PRK vaccine, how they work, this is the schematic presentation. So what to do the neovasculation, that has been covered by the ma'am too also. So always HSV infection, there is a tendency for the neovasculation. We have to be address these things. We can give the anti-VEGF or the topical your steroid very low dose. Even sometimes we give in the Kenacort injection to the steroid before the transplantation to improve the graft survival rates. So point to be pondered, the HSV endothelitis keratitis is a potentially blinding disease. Accurate and prompt diagnosis and the treatment with the steroid is necessary to prevent the long-term sequelae. Differential diagnosis of HSV endothelitis needs to be considered in atypical cases. Clinical diagnosis usually work well. However, microbiology and other laboratory tests, likely quantitative PCR of the aqueous humor, is informative for doubtful cases. And do we need to further research for prove the beneficial effect of the newer medicine? Yes, that's why Manisha madam is telling we have to be addressed by molecular think for the molecular level. And I hope that it will become soon, down the decades or years. Can we prevent the recurrence by eliminating the virus in the latent stage in the trigeminal ganglion by immunology or molecular biology? Yes, or by vaccination, by priming and pool vaccination methods. And can vaccination be used to increase the protection from the ocular herpes viral infection? Yes, that can be done. And these are the patient of the different panorama of the HSV, and these are all the smiling face of the eyes. Thank you very much for your
Thank you,
patience.